Yeah. Good afternoon. Can you hear me? It doesn't sound like it's on. Okay. Thank you for coming to the second. Turn it up. How's this? Any better? No? Louder. Yeah. Okay. So this is the second talk in this series on addiction, the scourge of modern civilization. And last week we had a general introduction and the use of naloxone, oxytocin for treating alcoholism. And today we are still staying, of course, with addiction, but we'll be moving on to marijuana. And marijuana, as you may well be aware, is being used medically now. And the title of the talk today is Medical Marijuana for Chronic Pain. Are we addressing an addiction or creating a new one? So today we have two speakers in this topic. The first one will be Dr. Robert Cook. He's a professor of epidemiology and medicine in the College of Health and Human Performance here at UF. And he also serves as a physician in the UF Health Internal Medicine Medical Plaza. He's the director of the Southern HIV and Alcohol Research Consortium and is the associate director of the Consortium for Medical Marijuana Clinical Outcomes Research. How do you keep that all straight? He's the associate, yeah. And this is a statewide consortium which was established in 2019 by the Florida statute to provide infrastructural support for research on medical marijuana and its clinical outcomes. Dr. Cook received both his MPH and MD degrees from the University of North Carolina. Then he interned in internal medicine at the University of Virginia before completing his residency in preventive medicine at the University of North Carolina again. Upon completion of his residency, he concluded his fellowship training in preventive medicine with the Clinical Scholars Program. Dr. Cook joined the University of Florida in 2006, and here he's combining clinical practice with research and teaching. And he has published over 150 peer-reviewed articles. So that's our first speaker, but I'll introduce the second one too at the same time. The second speaker is Dr. Yan Wang. She's an assistant professor of epidemiology in the College of Health and Human Performance and is the associate director of the Southern HIV and Alcohol Research Consortium. She's the assistant director of the Clinical Core Consortium for Medical Marijuana Clinical Outcomes Research. Dr. Wang received her MS and PhD degrees from Syracuse, and she's currently the PI or co-PI on multiple NIH projects focusing on alcohol use among persons with HIV, as well as a project that will utilize technology-based assessments to investigate the real-time and long-term effects of medical marijuana in older adults with chronic pain. She has published 25 peer-reviewed publications so far. Long way to go still, yeah. So Dr. Cook, please welcome Dr. Cook. And at the end of their talk, Dr. Perez, Joanna Perez, whom you heard last week, will do a little sum up and be also available to give. That's what you do. Oh, not today. Okay, at the end of 6. Okay, never mind. But she's here too if you want to ask questions. So, Dr. Roy Cook, please welcome.
All right. Hello, Okamic. Hello to people online. I also did hear that at least one of the audience members was interested in possibly staying after the talk with anybody who wanted to have a conversation about medical marijuana or any other topics. So at the end, you can look around and see if people are hanging out. But I was actually born in Gainesville and returned about 15 years ago and have been interested in studying alcohol and marijuana, both of which are commonly used by a lot of people, both of which in some people don't seem to cause that much harm, potentially clinical benefits, but other people it can be very harmful. And since this is a series on addiction, we're going to be thinking about briefly, is marijuana contributing to addiction? A lot of people are using it as a substitute for opioids, and potentially then it's better in harm reduction. And I'm going to be giving you just about 15-minute brief overview. Maybe I won't. So we hope that at the end of this talk, you guys can define what is medical marijuana, identify some ways that marijuana might help people with chronic pain, but also identify some possible harms related to medical marijuana use. So this is a picture I took. We went on a field trip to see a dispensary down in the Apopka area. They're a nursery indoors growing marijuana plants. So cannabis plants, cannabis you hear about. What is cannabis? What's hemp? What's marijuana? What's THC? What's CBD? So this plant is a cannabis sativa plant. George Washington was known to grow them. We know back in the 1800s, medicines from cannabis sativa were used. And it wasn't until about the 1940s in the United States when marijuana and other substances sort of became more of a Schedule I illegal product. But that plant there, you really can't tell by looking at it whether it's marijuana or hemp, because they are the same plant. But we create something called cultivars. So cultivars can produce either more or less of a chemical. And the products in marijuana include THC, which is tetrahydrocannabinol, and it's the Delta 9 variant. There's many variants, but if the plant has less than 0.3% THC, it's a hemp plant, and according to the federal government in the United States, it's hemp and it's not necessarily illegal. But if the plant produces more than 0.3% THC, it's a marijuana plant, and marijuana plants are regulated under sort of Schedule I, DEA, and FDA. So the plants are the same. You can't really tell by looking at it, but basically within the plant. So what is medical marijuana? So in Florida, medical marijuana is kind of regulated from the state government. A physician can certify a person to qualify for medical marijuana if they have certain conditions. Chronic pain alone technically isn't one of those, but many people with chronic pain can kind of get through the system and get a physician to certify them. And then that person is a patient in the system, and they can go to one of our either medical marijuana treatment centers, which is what the federal law, what our law calls it, or you can call it a dispensary. But you can go to the dispensary with your medical card and you can purchase products there. And the advantage in getting the product here, rather than maybe from the street dealer that comes around, is that the products in the dispensaries usually are labeled. They're labeled like a medical product of what the ingredients are, and they have been tested, and so you can feel more confident that they're not going to have heavy metals or pesticides or molds or fungus in them. And you can choose from a range of products. A lot of people do like marijuana flower, weed, or what you'd roll up in a joint or smoke in a bong, but other people use vape pens, and other people might use edibles like gummies. So the plant itself has over 100 cannabinoids and terpenes and flavonoids. So the cannabinoids are peptides. They're like medicine. THC is one, CBD is one. THC we tend to think of as more psychoactive, and CBD we tend to think of as not getting you high, but potentially reducing inflammation. But there's a lot of other cannabinoids. There's CBG and CBN. And then there's terpenes like limonene and pinene that give it a flavor of a smell and potentially have some therapeutic effects or side effects, depending on what people are looking for. And then there are prescription medications based on components of marijuana, such as a drug called Marinol, which is made from a synthetic THC, and Epidiolex, which is used for childhood seizures, and those is really a CBD product. So medical marijuana, some pharmaceutical companies have made prescription medication based on either plant-based cannabinoids or synthetic. And so in some ways you can also consider that to be medical marijuana. But a lot of people, even using it from a street dealer, would say they are using it for medicinal reasons. They're using it to try to treat pain or to sleep. And even though it's technically illegal to do that, people are getting self-reported medical benefit from that. So how does it work? So inside the body, we have an endocannabinoid system. The endocannabinoid system is based on a series of receptors, CB1 and CB2 receptors, for example. And the CBD1 receptors are mostly in the central nervous system, and the CB2 receptors are on our white blood cells or on a lot of different cells. And people who either, there is an internal cannabinoid system, which we call our endocannabinoids, and so that might trigger these receptors. If you use a plant-based product, such as the plants we were looking at, those cannabinoids, called phytocannabinoids, might trigger these receptors. And as I said earlier, that we can also produce synthetic products that can hit these receptors. These receptors do seem to be associated with different effects in the body. They seem to be associated with our normal body functioning. There's still a lot to be learned about them, but they do have sort of a biological basis as to why people would argue that medical marijuana could have a therapeutic effect. Medical marijuana can have many routes of administration. It can be inhaled or swallowed, or it can be a topical ointment. These different ways that you can consume medical marijuana vary in their speed of onset. So for example, a vape pen might give you instant relief or side effects within 5 minutes or so, whereas a gummy or some type of oral cookie, for example, it may be an hour or so before the therapeutic effect cuts in. And that can also affect the duration of the effect. And so as people think about cannabis or marijuana as a medical thing, you can also think about how these different modes of consumption either have a different speed of onset or duration of effect. Some people really come in on the ease of dosing. So if you have pain pills like oxycodone or OxyContin, it can be difficult to know exactly how much you need. 5 milligrams, 10 milligrams, there usually are options. But a lot of people comment that they like medical marijuana because they can dose it more precisely or in the moment just to get the right balance in what we call a sweet spot between a therapeutic effect and side effects. But it can be very frustrating if you're in the pharmacy business or if you're in the FDA business, because it is difficult to quantify exactly the dose of the specific components of marijuana people achieve when they use some of these products. So does marijuana help older adults with chronic pain? I suspect most of in the audience either have chronic pain or know someone who does. And anecdotally, maybe you've talked to some people who've tried different, either medical marijuana or CBD. And we hear different things. And the scientific agencies have recently been reviewing this. About 5 years ago, the National Academy of Science and Medicine said there is evidence in at least some studies that some components of medical marijuana do work on some types of chronic pain. But more recently, some of the national organizations that really represent pain and pain physicians have concluded that there's no evidence of benefit for pain. Now, why would we have this conflicting evidence? I would argue that many of the clinical trials are using sort of synthetic cannabis products, such as Marinol, or isolates of certain cannabinoids, which is very different than what people are getting at the Trulieve or the Fluent dispensaries in Gainesville. Also, many research studies rely only on the sort of the magnitude of pain. For example, on a scale of 1 to 10, what is your pain like today? And they're not seeing a lot of evidence of shifting along that pain score. But they may not be taking into account other reasons that people might benefit that I'll show you on the next slide. And we really have no studies that I know of that are really looking at products from dispensaries that you could purchase in Florida explicitly. And so a lot of the research we have is to to patients and physicians in the medical system in Florida makes no sense to them, because they will look at it and say, that's not how people really use it. This controlled clinical trial is different than what people in the real world are kind of using for benefit. So we really don't have a lot of research yet. There's a lot of legal barriers, a lot of issues that make it hard to study medical marijuana pain, although Dr. Wang will show you what we're doing. So how could marijuana help people with pain? I'm going to show you 5 ways. So one could be a direct effect. I showed you the endocannabinoid system. We do think that there's endocannabinoid activity associated with pain. People have tapped joints of people with joint inflammation and found increased endocannabinoids. And there's some other evidence that our natural body tries to fight pain. So that direct interaction with the CBD1 and CB2 receptors could be one way that marijuana could help. It could be helped by a psychological effect. In some qualitative interviews, again, you'll see some results later, but people might say, yeah, I have the pain still, but I don't worry about it as much anymore. Or I really was just worried about getting pain in the future and I couldn't focus, but now I just don't worry about it as much. So the pain's still there, 8 out of 10, but I feel better. Less stiffness and more activity. Again, I don't have a lot of scientific evidence, but some people have said they feel very stiff with their pain. It's difficult to move, and they don't want to move. They don't want to be active. But with medical marijuana, they're more willing to get up and move around, be active. Better sleep. A lot of people with chronic pain have trouble sleeping. And then when they have trouble sleeping and get up the next day, they may be irritable and feel bad. So if they sleep better, they may still have the same amount of pain, but overall feel better. And a big one could be substitution for other types of pain medicines. So people may say, well, I have the same pain, but I used to be on all these OxyContins or Percocets, and now I'm off of all that. I'm on medical marijuana instead. But a lot of people would say the side effects of Percocet was really bad, and the side effects of medical marijuana are better tolerated. So for those people, they still may have the same pain, but just be off of the pain meds. So there's a lot of different ways people could benefit from medical marijuana if they have chronic pain. So what are some potential harms? I left it blank in case you want to shout out any concerns. So smoking could cause people to cough and have trouble breathing. That is something that people worry a lot about. And so there are forms of medical marijuana that don't involve smoking, but the most popular forms do involve smoking. Any other? Addiction. I heard addiction, so I'll talk about addiction on the next slide. Driving. So accidents is what I put at the top of the list. So we really are worried about people driving under the influence. If any of your parents were around and they were on medical marijuana, you might be worried that they might fall or have an accident because they're off balance. Coughing, we mentioned. Severe side effects. Some people, when they eat a whole candy bar, for example, really feel nauseated. They feel paranoid. They feel tired. They might throw up. Nobody dies from cannabis overdose, but it can be unpleasant. And so people can have severe side effects because they consume too much. And then addiction, so cannabis use disorder. So I understand last week you guys started to get into a use disorder. So this would be someone that uses cannabis, but maybe persistently in harmful ways or dangerous ways, or people who develop a tolerance to it and need to use more and more, or people who psychologically spend a lot of their days and nights trying to get more marijuana, or people who say they just can't stop. They want to stop and they can't, so that could be a form of addiction. Good news is that marijuana is not associated with some of these things that you think it might be. In adults, we really don't see marijuana use associated with long-term memory or cognition loss. Now, that's in contrast to some data from adolescents or children who are really heavy users of marijuana. Although the evidence is not definitive, there's enough to suggest it could contribute to some cognitive deficits as people age. And another concern I didn't list on here is schizophrenia. And a lot of people are concerned about children or young adults who use medical marijuana and then having a psychosis. And anecdotally, I think that's a major concern for some people in the United States. And even though the data really don't suggest that it causes it, again, there's enough evidence suggesting a link that people worry legitimately. But again, no strong evidence of marijuana use in cancer. And even though it does cause coughing, and sometimes people with lung disease may not enjoy that, we don't see any evidence that smoking marijuana causes serious lung disease. So does it cause addiction? We did mention this cannabis use disorder, the physical dependence, risk to the health of family and work, unable to quit using as desired. So we recently did a survey of people in Florida. It says M cubed coming soon, but M cubed is now done, at least the part that I'm going to show you. Medical marijuana and me is the 3 M's. We surveyed about 600 people who were current medical marijuana users in Florida, and we gave them a questionnaire called the CUDIT, which estimates whether people might have a cannabis use disorder or not. And I guess we wanted to know what percentage of people in this sample of 600 looked like they were high risk for a cannabis use disorder. And you can think, was it 0, 10%, 50%? This bar graph shows the risk of cannabis use disorder among 629 adults using medical marijuana in Florida. The yellow bar is people that were high risk on this questionnaire, and that was 20% of the sample, and then moderate risk and then low risk at the bottom. So in some ways, good news that only 1 in 5 had a high risk for cannabis use disorder. But from a public health standpoint, we have almost 900,000 people using medical marijuana in Florida. If 20% of those have a cannabis use disorder, that's hundreds of thousands of people. So we really do need to pay attention to both the benefits and harms. So we wondered, who are the people at high risk, who are the people at low risk? And I have some more good news for this audience, in that the lower risk people were much likely to be older people than younger people, and much more likely to be using medical marijuana for pain or for sleep compared to people that were using it for anxiety or stress as a primary reason. So again, what we saw is for older adults using medical marijuana for chronic pain, there did seem to be a lower risk of cannabis use disorder and any type of chronic side effects. And that's my talk. So Dr. Wang is going to show you some more experimental research that we're doing.
All right, so I'm gonna talk about some data, hopefully not too complicated for everybody to read, from our studies. This is just no conflict of interest. I don't work for dispensaries, all that good stuff. Sorry. Oh, this is the way. All right, so before we start, does anyone know how many people in Florida are currently using medical marijuana? Sorry. He gave the answer. Oh, you already gave. What is the answer? 848,000, almost 850. And also on the right-hand side, we can see that physicians who can certify you for medical marijuana across the state, right now it's about 2,700 physicians across the state. All right. So what do you think are the main reasons for medical marijuana use? Why do people in the state of Florida choose to start medical marijuana as a treatment? Pain is definitely one of them. What else? What do you think? Stress, technically not a health condition, but yes. Anything else? Yes. Yes. All right, sleep. That's a big one too. Okay, so this is the study we did, and this is already talked about, but I just want to show you we do get people from across the Florida, the blue highlighted areas, that's where our participants come from for the survey. And then we have more females, male. I will get to the conditions, the reasons for use in a minute. And then more white people are using medical marijuana, looks like in the state of Florida. So here are the main reasons for use. So you see anxiety is on the top there, 61%, and people can choose multiple reasons for use in the survey. And the chronic pain is right there, second reason. Depression is also a big one. And then insomnia, sleeping problems, 37%. PTSD is also another big reason. And one thing interesting is that, I don't know if you guys know the 12 conditions that people can qualify for medical marijuana in the state of Florida. Many of these are not on the list. So it's almost like your physician will kind of make you fit into one of the 12 conditions that are qualifying conditions to get you medical marijuana. But these are the real reasons people say they use medical marijuana for. All right. So does it work? Well, let's see. So for those who said chronic pain is one of their main reasons for use, 77% in the cross-sectional survey. So basically, these are people who are using medical marijuana right now who take the survey, right? 77% among those who said they use medical marijuana for chronic pain actually find something that works for their condition. So 55% said flower works for their chronic pain. 43% said vape product, some kind of vape product worked. 42% said some kind of capsule or edible products worked. And then tincture, concentrate, so you find a little bit everything at the end, but primarily people find something that worked for them. But also 23% said they didn't find anything particularly effective for their chronic pain, right? And another thing people are interested in, obviously, is whether people can quit or reduce opioid use when they switch to medical marijuana. This is from the survey on the current users. So 0%, basically nobody said they increased opioid use after they started medical marijuana. 14% said no change. Basically, they stayed the same. And 45% said they decreased, so that's huge percent. And then 37% said they completely stopped opioid after they switched to medical marijuana. And there's a small proportion said unsure, 4%. So we see a big proportion of people, almost 81, 82% said either reduced or stopped using opioid use. So it looks like very helpful. So what might be a problem here with all the survey results we find? Looks like everything's working well, people are reducing opioids. What are some potential biases here? Why do we not believe 100% this will be a promising thing that we can all switch to medical marijuana from opioids? Placebo effect, okay, that's one good. What else? These are people who are currently using medical marijuana. Someone in the back. Fear of addiction. Good guess, but I don't think that's the real problem here. You'll be. Oh, CBD, okay. All right, so what I'm trying to get here is these are people who are currently using medical marijuana. That means they find it helpful. And that is why we find overwhelmingly positive results, because we're not asking people who started medical marijuana but have discontinued. So they're not in this survey anymore because they are not current users. So if you are using something, obviously you find it helpful. And that's why you continue to use it. So that's why I think this is not a very good study design, because we are asking people who are currently using and continue to use. And that is why we designed a study kind of capturing people at the beginning before they start using medical marijuana and try to follow them over time and see how many of them actually stop using and what's the outcome over time. So this is a study, a pilot study we did, basically recruit people when they get to medical marijuana clinic, but before they start using. And then we do some baseline assessment, for example, their pain level at the baseline, all that good stuff. And then once they start, we also ask them to report basically daily, what are your symptoms of pain, what are your sleeping look like, and then we also followed after they start medical marijuana. So basically we capture people before they use and also capture their outcomes after they use. So what do we find? So basically, this is a small sample, only 56 people, mainly people over the age of 50, primarily white and highly educated sample. These people all have high level of pain, 8 out of 0 to 10 scale. So what we do, we ask people to do survey, but we also ask people to do some brief surveys on their phone so we can get real time. For example, if I ask you out of 0 to 100 what your pain level is right now, people will have different answers, and that may fluctuate over time. So this is just some graphs that you can plot over time. I just want to show you these are different kind of trends people's pain look like over time after they start medical marijuana. So you can see someone who declined, their pain level declined a little bit, but then bounced back. There's this person whose pain started at 70, but declined to almost 0 after starting medical marijuana. And we also have someone who basically stayed the same. So there's a lot of individual differences in their response to medical marijuana. But overall, the 56 participants reported significantly lower pain. So these are just some self-reported measures of pain, of pain interference, and they also reported improvement in their depression. So basically, they said they're less depressed at the end of 3 months. Also, we found that people said they were able to reduce their opioid use. So some of these are daily opioid users at the beginning of the study. 53% at the baseline declined to 29%, essentially, at the 3 months. And then they also reported significant increase in their hours of sleep and the quality of sleep. We also have a quality of life measure, and they reported better quality of life at 3 months. But remember, this is at group level, so we still have that individual differences. Some people may have better outcomes than the others. So what do patients say about medical marijuana? So we actually did some additional qualitative interview just to get people's feedbacks on their medical marijuana treatment at the end of the first month's treatment. So these are some comments from patients. So this person says, it makes it much easier to control pain and not take pills. The side effects are way better than tramadol medication. On medical marijuana, you can live life, work, and do stuff, but on tramadol, you cannot keep pain-free and do stuff. So this is getting to the functioning. So the side effects compared to other more conventional pain medication. So this person said it's very effective in helping my pain when everyone had to go down on opioid because of the high death rates. I felt suicidal. It takes the edge off plenty where I feel human again. So this person talks about the opioid. Basically, you need to cut down your opioids. A lot of physicians stop prescribing, and people feel withdrawal symptoms, all that. And this person basically said medical marijuana helped. This person says, it helps me move. Normally, when I would come from work, I would be a lump on a log and couldn't move. And now I can move around freely, interacting with my family members. So this is getting into your relationship with family members. Looks like this also helped. This person said something about the threshold of medical marijuana. So it can help you to some extent, but at the end it says it's useful in reducing pain in moderate levels, but not high levels like opioids. So some of them find some limitations of that. And just to also bring that up, there are a couple of patients who said, to be honest with you, it didn't make any difference to me. So again, majority said some improvement or a lot of improvement, but there are a few people also said no difference. And this is about, sorry, did that advance again? This says about opioid use. Overall, medical marijuana treatment was helpful, especially when going through narcotic withdrawal. And this person also said, I'm no longer using my walker, I only take my meds. So this talks about they were able to reduce their medication. Basically, they said, I haven't had a Xanax in 30 days. Let's see. And also this set of quotes basically talks about some side effects and undesirable things people experience when they take medical marijuana. So this person noticed some weight change, but they said they can afford to lose some weight. And the second person here basically said they didn't enjoy the way it makes them high. So this person is not looking to get high, but the product, one of the things is that it makes them feel that. All right, so I do want to say that we have an ongoing study basically built on that 3 months pilot. So right now, this study is ongoing. It's called a SMILE study. We're looking for older adults with chronic pain who either stay on their current pain treatment, or they are looking to start medical marijuana, and we're gonna follow them over 12 months to do some assessments. So this is our study website. It's called smilephhp.ufl.edu. And we need participants. If you think you would qualify, you're interested, feel free to contact us, check us out. There is a contact form you can fill out online, or you can just go to contact us. There's text or phone number you can use. So just to wrap up, people with chronic pain experience both health benefits and side effects from medical marijuana use. This is from our study data. But as Dr. Cook said, there's so far insufficient evidence regarding a lot of things. So I guess I can just take questions or anything. Thank you for listening.
So for Dr. Cook, I was surprised to hear you say, I think I heard, that you haven't found an association with lung disease and marijuana smoking. And I thought if you inhale anything into your lungs, it's just dangerous. My guess is nobody smokes a pack a day of marijuana. Is that why? Or could you explain that?
Well, when you think about lung diseases, certainly if you have asthma or some type of COPD and it does make you short of breath and cough, in the short term, it can cause breathing difficulty. I was referring more to long-term consequences, like would it cause COPD, would it cause lung cancer, or would it cause some type of long-term chronic breathing? In fact, some people argued that because people inhale deeply, if they smoke marijuana, that it could actually expand lung volumes. And we did see one study that showed that the marijuana smokers had larger lung volumes. So on the other hand, if people do get from marijuana smoke a lot of this black stuff that is fairly nasty. So I think a lot of older adults just prefer not to try smoking.
My question is for the SMILE study. Will you be providing them with prescriptions, or do they have to sign up somewhere else to get the prescriptions and then sign up with you?
Yeah, so we got that question from many potential participants. Unfortunately, we are not able to provide any prescription, but we do provide all the necessary information about how you can get your medical marijuana card. We have collaborating clinics who people can go to get their certificate. And we also provide some financial incentive to help people with the medical marijuana card.
But without the control on your side for the prescriptions, how do you know what the people are saying and how they're getting a prescription, or is it some doctor in a box or whatever?
Yeah, so we ask them to show us the medical marijuana card once they get it. So basically, we validate that they get their card.
No, sorry.
Oh, and as you said, it's always hard if people lie to you, but we ask them to report very detailed information on the medical marijuana products they get, and we do blood tests to kind of verify their blood level of the cannabinoids concentration. So we kind of have self-report data. We also have some biological markers. So if that's what you're trying to get.
Okay, we have a few chat questions. The first one just says flower is generally smoked. Next, it says, in the second study, did you ask if they were currently using opioids?
I'm not sure which second study. Is it SMILE study or? But yes, we do ask all the questions about their medications, including opioids and other medication. So basically, we get a very detailed information on all the medication, essentially.
And then the last chat question says, did you take data or testimonials on the impact of regular marijuana use on working memory?
And another, I think, are you studying cognition in your study?
We do. We probably have one or two tasks that get into the working memory. So we use a tool called NIH Toolbox, which is an iPad-based app. Ask people to do a few thinking memory games to assess their cognitive function. So we do get that data at the beginning and every 3 months until people are done with our study. So we do track that information on cognitive functioning.
And I'll just comment that on the flower, many people do roll it into joints or smoke it in a bong. That involves burning it, setting it on fire. So in addition to inhaling the smoke, it's also very high temperature. Some people get what's called a dry herb vaporizer, which heats the flower but doesn't burn it, and that's probably healthier, although we don't study it directly. And then people can cook it and bake it into brownies and cookies like people used to. And the advantage in that for many people is that they get the full plant effect and not just the THC.
I'm wondering if you've done any analysis based on the source of the pain. Is there a difference of the effect on bone pain versus muscle pain versus migraine versus vascular pain, cardiac pain? Differences that way?
There's definitely publications, and also in our study, the SMILE study, we have a pain expert who provide all the guidance, like how we assess pain. There's pain state, different pain state, different causes of pain. We have not been able to analyze any data at the moment because we only recruited about 70 some people. So, but in the future, we definitely will analyze. But in the SMILE study, we only recruit people with muscular skeletal pain. So it's not like all the pain, because we cannot study such a diverse sample without kind of, we need more people in each group.
I think the clinical trials we've seen have been on something called neuropathic pain, which is kind of a burning or a numbing sensation in the arms or the feet. And there was a clinical trial that in the lab, people got more pain relief from marijuana than placebo for neuropathic pain. Yeah. But certainly when we talk to people, they have a broad range of pain conditions, everything from spinal rods in their back to migraine headaches is one that people say they use it for. And there's been no specific study that we know of on migraine headaches.
I'm interested in marijuana's effect on inflammation. You mentioned that. Could you go into that a little further, please?
So we again, it's hard to measure. So inflammation, systemic inflammation involves your body producing cytokines. One is called interleukin-6. There can be something called C-reactive protein. If you measure just adults in the population, people with high inflammation will be at higher risk of heart disease, cancers, dying early. And so if they have chronic inflammation, we tend to think that's a bad thing. And there's a lot of hype and belief that CBD can suppress chronic inflammation. And I've seen some uncontrolled studies that suggest it could reduce inflammation. But we really don't have a lot of clinical trials in people. I've collected biomarkers of inflammation that we're going to look at in blood tests and kind of compare marijuana users and non-users. But a better study design would be what Dr. Wang's doing, where we could sort of look at pre and post measures before and after in a group who starts medical marijuana versus a group who doesn't. I think another unanswered question is the role of CBD in the chronic inflammation. So a lot of the hype, meaning if you go online or read what people think is going on, they'll say CBD is the component of cannabis that's probably most related to chronic inflammation. We know that there's CB2 receptors on cells, immune cells, that produce these cytokines. And so we have a logical reason to think it could suppress inflammation. And I mean, people were even talking about it as a COVID treatment because it might suppress chronic inflammation related to something like an acute COVID attack. So I think that there is a lot of interest in that, and I think that a lot of people believe it, and we just don't have any strong evidence yet to prove it.
How does the status of marijuana as a Schedule I drug affect your approval requirements for research methodology, and how might it change if the status I was removed or it moved to a different status?
Right now, one of the biggest barriers we have as researchers is we really can't possess the marijuana product. It would be illegal for me to possess a marijuana product unless I was a patient and I had obtained that product from a dispensary. We have a lot of people using marijuana off the street, for example, that they get from a dealer, and they think they know its potency. So we would love to be able to get a sample from them and send it to a lab and say, analyze this. What's the percent THC? What's the percent CBD? But it's illegal for us to possess the marijuana. It's also illegal for me to deliver it to a lab to have it tested. So I do believe that Schedule III would change that a little bit so that we could possess the product as a researcher, we could get it tested as a researcher. And I think that some of the stigma around it being, a felony to sort of possess it technically, even though in Florida the state law says it's legal under these circumstances, there's still really a strong stigma to having something that people say is a felony. So I think that people may feel less stigma about talking about medical marijuana. Right now, a lot of people, even if they're using it, might be reluctant to admit it to their family and friends because they might feel they would be judged, and I think that Schedule I is part of that judgment. the biggest barrier to doing some of our clinical research is actually at the FDA. If we're looking at a clinical trial to reduce pain, or hers is observational, so it's not a clinical trial. But if she really was to randomize people to medical marijuana, or let's say a placebo product, the FDA would be interested in that study, because in the end, someone might label their product as effective for pain. But the FDA doesn't have a good mechanism for dealing with this plant-like material. And that's been a big barrier, and I think it would continue to be even if it's Schedule 3.
Would psychedelic mushrooms fit into any of your studies?
Psychedelic mushrooms?
Not right now in the study.
It's a hot topic. Psilocybin is really a hot topic for addiction. It's a hot topic for people who have PTSD, low dose. It's currently not legal in Florida, but more and more researchers are doing it. And I think that you have a talk later in this series that will discuss psilocybin and mushrooms.
Hi, this is not directly from the data that you presented, but what are your opinions about long-term heavy use of marijuana and its effect on central nervous system functioning?
I had a PhD student who looked at people who were daily smokers for 20 years in a cohort study where they looked at cognition and function and compared it to either occasional users or non-users. And if anything, there was a signal that their cognition was better. I don't see a lot of effect on physiologic function. So again, for people who are adults, meaning they're like in their mid-20s or older, acutely, it does have an effect on people's ability to walk. So if you smoke marijuana and you feel high, you may not be able to walk in a straight line. You are going to be much more likely in a car to cross the yellow line. You might get dizzy and fall. But in terms of after that acute effect wears out, my opinion and interpretation of the data do not really show any long-term effect from daily marijuana use. And a lot more people are using it daily and at doses that don't necessarily get them high.
I have a follow-up question on this too. You said that there are those two receptors, CB1 central, CB2, which is peripheral. And then you also had data that young people tend to get addicted more than the older people. Is it because perhaps the older adults are taking marijuana for pain, which would be peripheral, rather than the youngsters who are using for anxiety, which would have central nervous system effects? There a difference to where it's acting and therefore getting more addiction in younger people than older ones. Have you looked at that?
I think you're just asking, is the mechanism it works on pain
Yes.
maybe different? My suspicion is that more of the younger people are using it to kind of mask or numb other symptoms of anxiety or stress.
Right,
and so they're just kind of trying to block something that is not physiologic. It's coming from an external source possibly, whereas the pain is internal. The pain is coming from inside the body. So potentially that could be one reason. But I think that for younger people using it for anxiety or depression, and they may just be using it to try to escape reality or escape the world a bit, that's probably not the best solution for them.
Yeah, okay.
In the older patients, just anecdotally, they tend to be more cautious with dosing. They always start with very low, and sometimes the medical marijuana physicians say they are afraid to go more than maybe 5 milligram, 10 milligrams, so they tend to be kind of more cautious.
I see.
I would say.
Yeah, thank you.
While we're getting to that one, there's one other comment. Would it be useful to assess executive functioning to see if there are negative effects of medical marijuana?
So again, executive function is a type of cognitive assessment that basically involves things like planning, and I know many of you in the room are probably scientists or psychologists, and you can think, how do we measure motivation? How do we measure planning? Because stereotypically, marijuana might cause people to sit on the couch and watch TV all day long and eat potato chips, as opposed to get out and come to a lecture like this, you know? So how do you measure that stuff? It's very challenging, but again, we're doing our best to try to assess it. It's just if you measure people who are current users and compare it to people who are not, it's just really hard to tease out whether any differences you see existed before. Because in general, the type of people that use medical marijuana might be sicker people to start with. They might be more likely to have PTSD and anxiety. And so in some ways, their health is going to look worse compared to non-users. So I think the strongest data we're going to have is either a clinical trial or a prospective study. And at least our team is interested in measuring different aspects of cognition, including memory, planning, executive function, remembering what you're supposed to do tomorrow, having life goals that are beyond the next TV show.
Doctors, can you provide me with referral to a CBD licensed physician for my sleeping problem? I have no pain. How do I get evaluated?
I missed the beginning of the question. Could you repeat?
How do I get evaluated for my sleeping problem by a licensed physician for CBD? I have no pain, only poor sleeping.
So CBD can be purchased without a prescription, and it can be ordered online. It's available in pills, capsules. It's available in tinctures. So you don't necessarily need to see a medical marijuana physician to get access to CBD. And after, again, even reading reviews on Amazon Prime, you could probably get some CBD. There are stores in Gainesville that sell it. It's hard to know. Our state government was supposed to be monitoring CBD as well to make sure that the ingredients on the label. A lot of people might see CBD in a gas station, or they might see other types of cannabis in a gas station. And I would just say, let the buyer beware. We do feel more confident. You can get and see a medical marijuana physician, go to the dispensary, and they do sell CBD products there. They call it low THC cannabis. And as far as getting a certification just for sleep, again, it can be, technically that's not a condition on the list, but the physicians often find a way to sort of work with you to sort of find the best solution. Some medical marijuana physicians will be very interested in working with you on sleep in a lot of ways. Others just might be trying to get you in and out in 15 minutes, give you a card and move on. So we do have a few recommendations from physicians that we think are really good that we can share with you after the meeting.
What are some of the conditions that physicians are allowed to prescribe marijuana for? You mentioned what people want it for, but what are the ones that they're allowed to?
Yeah, I think cancer, HIV,
real illnesses.
glaucoma, yeah, like a real serious ones. But there's like a similar condition, so that's where the physician can have a little bit of room. Like so there's a report that the Board of Medicine put out every year. So under the other similar condition, a lot of people are saying anxiety, sleeping issues, and chronic pain. So chronic pain is technically not on the list unless it's with one of those like serious conditions.
Related with
yeah,
this,
but there's way they can put like other similar condition. So sleep problem or insomnia is among one of those.
Yeah. Okay. Are there any more questions? Okay, if not, thank you very much. Appreciate your coming out here.
And again, did someone want to organize a discussion after this?